community physician in Sri Lanka who is deliberately work for the community health and public health system in Sri Lanka. So this is our very good opportunity to get his experience and implement it our future project and future actions. So let me welcome the Dr. Kapila Jayaratne.
After the lunch, you all may feel a little sleepy, but I will try my best to keep you awake all throughout. What I am going to talk to you today is how the maternal and child health service delivery is organized in Sri Lanka with a focus to birth defects and to club food. We started our maternal and child health service delivery way back in 1879. We were under British rule, and thanks to them, we got this Soyza maternity hospital. I think it's the first ever maternity hospital in the South Asian region. And then the main turning point of the Sri Lanka's maternal and child health is the start of this public health services. So, field maternity and child care started in 1926 as a pilot project under British rule, and then it was expanded to cover all the households in the country. That is the crucial point. We started all these programs in 1968. Family Health Bureau, where I worked for 15 years, and altogether in 27 years in the Ministry of Health. So it started in 1968. Next slide. Thanks to these global initiatives in primary healthcare in 1987, Safe Motherhood, and 2000 the Millennium Development Goals, and 2016 Sustainable Development Goals. As a country, we were targeting all these goals, and we at all the times we achieved them. And the basis of our maternal care is based on scientific evidence and continuum of care. So we adopt a life cycle approach. I mean, starting from pre-pregnancy, then pregnancy, postpartum, family planning, and then again adolescent health, well-women clinics as a cycle. So it's a life cycle approach. It's a continual care using the health system both at the home, household level and the community level. So there are referral pathways. Any person in this country, if the person is ill, they can reach to a hospital anywhere, and within 30 minutes they can receive the required health care. So that is the beauty in our system, either in the private sector or in the government sector. Within a radius of 5 kilometers, you find an MBBS qualified doctor in this country. So, our services are expanded everywhere, and the availability, accessibility, and ability, all three A's are there. So capacity wise is always who can prescribe is a qualified MBBS doctor. So no other people cannot give medications to general public. So that is the rule in this country. So that we maintain everywhere, even other categories of healthcare workers except vaccination. All other medications are given by doctors. So this is the model of Sri Lanka's maternal and child care. You see, I was talking about the life cycle approach, starting from the marriage, then care for eligible couples, then family planning, women's health, pre-pregnancy care, antenatal care, intranatal care, postnatal care, infant and child care, then again school health and adolescent youth. So it's a continuum of care throughout the life cycle. So these are just a schematic representation of the domiciliary and clinic care we provide. So we register all the pregnant women before 8 weeks of pregnancy. So then the registration coverage is 80%. Then there are steps can you move, throughout the pregnant period and after the pregnancy period. So at the hospital there is a newborn screen. So where we pick all the birth defects including clubfoot, and then there are household home visits conducted by the public health midwife, and there are many encounters with the healthcare system. Each and every child is seen by a medical officer, and all these are spelled out in a maternal care package. All the steps, whatever is to be done by the public health staff in the field setting are outlined in this package. So we train all the relevant people with the help of a training system, in-service training package we have. Now Dr. Harita is happened to be a divisional level healthcare manager. So he was trained, the first he has the qualification, then he was trained in the National Institute of Health Sciences for 3 months, how to deliver public health care for the people. And then again, periodically we have pre-pressure programs for them to further develop their capacity. So this is the public health midwife at the village level, household level. They provide care. They have all the information. All the households are registered. So this is what I was telling. Apart from the general practitioners, first contact physician, we have emergency neonatal and obstetric care facilities all throughout the country. These are forest areas. All other areas are covered within the proximity of 20 kilometers. Any person in this country can reach to a specialized hospital. So built in this system is the data. So without data you can do nothing. So we have a rich data system. One is the routine healthcare data, and also the surveillance data. So we have registration of marriages by the public health midwife, then eligible couples registration, then family planning provision, pregnancy registration, antenatal care, and hospital delivery is 100%. All the pregnant women deliver in a hospital. I know in some of your countries, so still there are room for improvement. I happen to visit several countries. So how to improve skilled birth attendance. So actually we reached this about 10 years back. The last phase we were little struggling, but ultimately we achieved 100% in birth registration, postnatal care, and this is what I was telling. The beauty is that we register all the pregnant women before 8 weeks, 80%. So that is why our health indicators are very good. Our maternal mortality ratio is 29. That means when 100,000 babies are born, only 29 women die in this country. Stillbirth rate 6.1, neonatal mortality rate 5, and infant mortality rate 7.4, child mortality rate 8.7. So every year, as I mentioned in the morning also, there are about 275,000 babies born alive every year, and these are the figures on births, deaths, and marriages. We have latest data, and all these we do with strategic plans. So we have national policies, and based on national policies, we develop strategic plan in specific areas. So this is the national strategic plan for maternal and newborn health. Uh, so we have a good vision. So where we need a country where there are no preventable deaths of mothers, fetuses and newborns. That means we need to reduce these deaths, where every pregnancy is planned and wanted. That means we have to provide proper family planning, and every birth celebrated. This is what I want to highlight. So not all the babies born in this country are healthy. So some may some are born with defects. So one of that defect is limb defects. So that is why we are focusing on this aspect also in our vision, and we want to ensure that they are developed as adults in future. So this is the overall national strategic plan, and now we are trying to achieve sustainable development goals by 2030 with these targets in mind. Less than 10 less than 10 maternal mortality ratio. So these are on par with European countries. So very ambitious targets, but I think we may be able to achieve them. So, but what you are worried about is the number. Now we are not focusing on rates or ratios. So we have just 89 maternal deaths all throughout the country. Because you know why I can put these numbers. We have rich data, quality data coming from all over the country. So that is thanks to the health information systems we maintain. So it's not easy. I know in almost all other countries, your countries, it's very difficult to get people to report. Even in our country it's the same, but you know, you have to put your sort of pressure on them and get them done, because what we Faisal wants me to tell about the advocacy role we play at the Ministry of Health, and because in Sri Lanka, all the communications, all the instructions are given to healthcare workers by way of circulars and regulations. So people are expected to oblige. There are very few instances where the healthcare workers do not oblige. We don't have to sort of punish them, but by virtue of their behavior, they oblige. So apart from a few instances, usually we don't embark on disciplinary actions. Then all these are complemented by public health surveillance. So we have surveillance mechanisms in many areas, especially in death surveillance, the child deaths and maternal deaths, and also specific deaths, say dengue related deaths. So that is why we could do a lot in COVID-19 pandemic also. So usually what we do is we utilize this data for action at various levels. So surveillance data, individual data, which covers the every aspect and quality data, and we receive them in time. So I mean, we don't get it. I mean, in latter parts of the later years, but every year we get they are in time. That is why I can present these data also. So because of that, we have these surveillance systems covering. This is one of the elements we have is the birth defect surveillance, because many countries still focus on mortality surveillance. Now we have gone beyond that, and now we do birth defects, even child suicides and child injuries, because out of these data we do lot to reform or improve our system in the country, and these are very essential for health system strengthening. So this is the WHO framework for health system strengthening. So delivery of patient services, healthcare workers, health records and patient information, leadership, financing, and medicine and vaccine. So we cover all these at the central level and also at the peripheral level. So uh, because of this, because we address all these system uh, building blocks at each level, we perform very well as a country and delivering needy healthcare for people. So, uh, uh, with a focus on birth defects, so we did a survey in 2013, and we found a prevalence of 1.8% birth defects in the country. And in the morning I revealed this data. So we get around 4,000 to 5,000 babies born with birth defects. Out of them, 30% seems to be serious birth defects. Even though they survive, they cannot have an independent life. So the number one birth defects is heart defects, then limb deformities 20%, and cleft lip, cleft palate, genetic diseases. Genetic diseases means Down syndrome and all. This includes neural tube defects. So I want to focus on congenital heart diseases. So where we are doing best, but still we are struggling to give total care for them. There are some waiting lists for the cardiac surgeries and limb defects. Before that, I come to cleft lip. So we have totally giving total care for these children. So there is no child now we see with a cleft lip. So they are all of them are treated at tertiary care hospitals. And then comes the genetic limb deformities. The number one is clubfoot. So Dr. Gayani also in the morning revealed that we have nearly 400 to 500 cases in the country. So now actually we capture about 300 cases, but we want to expand these services to cover the entire country. So hospital admissions wise, these children with birth defects number wise nearly 10,000, and we spend a large amount of money in caring for them, and that is why we focus on counting these cases and preventing birth defects. We consider it as a national priority, and we have again, as I mentioned earlier, birth defects prevention and control national plan, which this was developed in far back in 2014. Now we have revisited it, and last year we finished restructuring the care pathway, and we came up with a new national plan. So it will be released very soon. Birth defect surveillance I was talking about, and these are the capture points for birth defect surveillance. So each and every newborn born in this country is subjected to a newborn screening. The coverage is 99%. So it is done by a medical doctor before the discharge, and there we identify all the birth defects which are visible at birth. So if a baby with clubfoot is detected, there is a referral pathway which the baby ends up in a tertiary care hospital receiving adequate care. So then at well baby clinics up to 5 years, they are seen by the qualified medical officers, and if they find a defect, they are referred for specialized care. Then we have school medical inspections up to grade 11, then pre-employment screening, then once they get married, pre-pregnancy screening, assessment and counseling, and during the pregnancy period also we can find cases of birth defects. So, and we have a huge network of first contact doctors, either general practice or OPD settings in peripheral hospitals, where we can capture children with birth defects. So in 2016, we started this national birth defect surveillance system in the hospital actually, hospital sector. So we are yet to start it in the field sector. So hospital has a very good referral system where we capture at each level a child with birth defects and also a child with clubfoot. So we have specified capture points, hospital data flow, hospital birth defects registry, and there is a case abstraction form. And as I mentioned, all these are implemented through circulars sent by the Ministry of Health, and they are centrally implemented and monitored by Family Health Bureau. And we have now web-based National Birth Defects Registry, and so we can do analysis also. And for all the hospitals, we have this wall charts placed in all the hospitals, and we can do this, but we need awareness among general public. So every year, World Birth Defects Day, we carry out these awareness programs to general public. So this year also we are planning to do the same thing, and we are happy that we are getting support from Miracle Feed this time. And all that is, I think you might get some sort of inputs for you to do, replicate these things in your countries as well. So but my advice is start small, then we can expand it nationally, and you can start it at a hospital. Later on, we can expand it. The good thing in Sri Lanka is, because we are a small country, only 22 million population, geographically also small, we can advance because many things are centrally governed. So, and we have a good authority over all the healthcare delivery system points and also people. So they are usually obliged. So that obligation binding is very important. So I see in some countries you can't have a sort of central grip on your healthcare workers, including doctors. Here also the system was so, but gradually we could incorporate this binding culture among our healthcare staff. That is why we could excel. Thank you very much.
Thank you so much.